Kidwai Institute has made a lot of difference in identifying and serving the people. I'm really surprised whenever I used to visit Kidwai Institute to meet Bafna. They are catering the patients from all over South India, and Karnataka people are very small number, and such a huge work and such a beautiful work. And I think they are one of the pioneers. And today we have our own Bafna. Why I'm telling our own Bafna is we are together postgraduates, and since then we are so close and so known to each other. And 15 years back when I started the PGCME, he was the only speaker to speak on the oncology. I had no other names at all. And since then, every year he visits and he always makes it a point to join for the PGCME. More than that, today, the postgraduates are asking, have you called Dr. Bafna or not? Such is the status today. And just last week, when Murli finished his program and organized it in a very short time, then I contacted Vidya whether she has come back from the foreign trip or not. She said, I have come, but what about the speaker, whom to search? Then we went on searching speakers. Then one day I told, why don't you look for Bafna Vidya? And gynec-oncology subject has not been covered for a long time. And lot of skill transfer is needed in gynec-oncology because all cannot get a MCH in gynecology. And all of us has to do gynec-oncological surgery. Only people like Bafna who are experts in the field can teach each and everyone. And today it is the need of the hour because gynec oncological problems are the leading cause of death in women. Cancer cervix, cancer breast, cancer uterus, ovary, they're all the leading cause of death. I think mortality in the woman can be brought down to a very great extent by doing a proper management of gynec oncology. And Bafna is the right man to guide us. What is the right management as on today? And topic also he has selected very excellent topic. Dr. Bafna, again, once again, I welcome you on behalf of KCOG and KCOG, and the now the whole stage is yours, and large number of people are joining. I think it will be a feast of knowledge with expert knowledge of Dr. Bafna. Welcome you, Bafna, once again.
Thank you so much.
Thank you, sir. Thanks for the nice words and thanks for suggesting that what do? We are so confused at times, and Hiramad sir is always there for help. And it's my great pleasure. Arun, I want the CV, please. It's my great pleasure and proud privilege to introduce Bafna sir because as Hiramad sir said, he knows him since his postgraduate days, and I know him as a teacher, as my postgraduate teacher when I used to go for my posting in Kidwai. And since then, sir's operative skills are immensely appreciable. And he is not only a very good open surgeon, he is a lap surgeon and a robotic surgeon also. A beautiful combination of all the three surgical skills. And all of you know that it was Bafna sir and Kidwai. Anything Kidwai, it was Bafna sir. So he has been the HOD and he has been instrumental in getting MCH in Kidwai, and many people have been trained since he fought for that position and seat and got it. And that has helped many of the gynecologists to branch out to a branch of gynec or gynec onco so that they have a specific field to work on. And also he's been a recipient of BC Roy Award and Gnanavarsha Best Teacher. BSOG has always welcomed Bafna sir, and Bafna sir is always there for BSOG whenever we need him for any lectures and any CMEs. On the lighter note, I would like to add this. It is said that Bafna sir is so quick in his Vardaims or radical hysterectomies that he finishes radical in artery, cautery, light and tight. By the time he says tight, the surgery is done. He's so fast. And one more on a lighter note, which I always tell him, that he never ages. Bafna sir is always the same. So I always call him the Madhumaga, of the onco surgery. Over to you, sir.
Thank you. Okay, thank you. Thank you so much for the wonderful introduction. And I would like to thank Dr. Vidya for inviting me for today's talk. And also I would like to thank all the office bearers of Karnataka College of Obstetrics and Gynecology. So today I have chosen a topic of role of minimally invasive surgery in the field of gynecological oncology. So please allow me to share the slides. Okay, I hope my slides are visible.
Yes, yes, yes.
Yes,
Thanks.
sir.
Okay.
Yes, sir.
Yes.
Slides are visible. MIS in gynec oncology.
Okay. So all the faces are actually familiar here. All those pictures, what I'm seeing on my screen, everybody is almost like family to me. So I will not take any particular name, but all of you are like my family. So it is nice to be here. So now minimally invasive surgery in gynecological oncology has evolved in the last 1 decade. After gaining widespread expertise and skills learned during routine gynecological surgeries. I think way back about 30, 35 years back, 40 years back at Hubli, I think Dr. Kavalgod, I think we had started the laparoscopic sterilization. So I think Hubli was number 1 those days as far as laparoscopic surgery was concerned. Since then, I think we have come a long way. Now, I think many people have developed expertise in the field of minimally invasive surgery. And I'm seeing a lot of gynecologists and gynecologists all over across the country, including Karnataka. They have become excellent surgeons. So it's wonderful to watch all those surgeons doing excellent surgeries in the field of minimally invasive surgery. So many gynecologists have started doing gynecological oncology. So I think we need to have more knowledge about when to venture into laparoscopic surgery and when not to venture. So let me give a brief outline about my own personal experience, how I started and how I learned laparoscopy and where do we stand today. So it is very important for the gynecologist. Nowadays, I think we have many patients coming with endometriosis, deep infiltrating endometriosis. So very important for the gynecologist to be familiar with the retroperitoneal anatomy to avoid injury to ureter, rectum, pelvic vessels, and the intestines. So because endometriosis is more dangerous than oncology. The adhesions are very, very dense and very difficult to get surgical planes. So it's important that we have a good knowledge about the retroperitoneum. So this is, I think, a brief video showing the retroperitoneal anatomy while doing radical hysterectomy for CA cervix. Nowadays, I think we are not doing radical hysterectomy for CA cervix. We mainly do minimal invasive surgery for carcinoma endometrium. For the reasons I'm going to tell you in a short while. So creating pararectal space, I think most of the gynecologists who are doing surgery for endometriosis are familiar with this anatomy. So you must know how to create the paravesical space, pararectal space, identify the uterine artery at the origin, etc. So the type of surgeries which are carried out in gynecological oncology, mainly we do total laparoscopic hysterectomy, bilateral salpingo-oophorectomy with pelvic lymph node dissection and sometimes aortic lymph node dissection, which is a little more difficult. And radical hysterectomy was being done for carcinoma of cervix, but of late it has gone into disrepute for various reasons. And sometimes we do surgery also for ovarian tumor. So we have to do omentectomy also. And of course, laparoscopy is very, very useful as a diagnostic tool to know what is the cause of disease. So laparoscopy is extremely important as far as diagnostic tool is concerned. And sometimes in ovarian cancer, normally we resort to laparotomy. There is almost no role for minimal invasive surgery because disease is very widespread. But sometimes when you have limited disease in the abdomen, then you can venture into laparoscopic surgery even for ovarian cancer. And very rarely we do exentration. Exentration, I think, is very good, laparoscopically very good, because you get very good planes with laparoscopy. I think it's better than open surgery. Anterior exentration, total exentration can be done very well with laparoscopy. Now I started my career with open surgery. So many years, almost 25 to 30 years, I was doing only open surgery. One fine day, suddenly we got laparoscope and we had to switch to laparoscopy. I started learning laparoscopy, then robotic surgery came. So then I had to develop expertise for robotic surgery also. So what I mean to say here is that switching for open surgery to laparoscopic surgery to robotic surgery, you have to have a different mindset. All three surgeries require different mindset. So you need to proceed carefully to avoid even small bleeding in minimally invasive surgery. In open surgery, bleeding, you can put a mop, you can control the bleeding. But in laparoscopic surgeries, better to proceed slowly so that you avoid bleeding. And bleeding is the biggest hindrance for laparoscopic surgery because it will block your vision. Then another drawback of laparoscopic surgery, especially in oncology, is that sometimes you are required to do surgery for 3 hours to 4 hours, sometimes even 5 hours also. So you'll be staring continuously at a TV monitor. So you may get eye strain and you may get back pain, shoulder pain, all those things. So you must be ready to do all the things. You must keep moving your feet, keep moving your back so that you don't get backache. Keep moving your shoulders. Then you have to have different energy sources in oncology. One source may not be enough unless you are an expert. You have to have a harmonic, you have to have a bipolar, you may have to have a monopolar. So many different energy sources you have to be mentally ready to use. You need specialized hand instrumentation for with the different ergonomics in laparoscopy. Now, there's some drawbacks also in laparoscopy. When you're switching over from open to laparoscopic surgery main problem is that the movements are non-complementary. Laparoscopic instruments move in a non-complementary, they have non-complementary movements. So our mind has to get used to it. And it has got limited range of movements compared to open instruments. Then 2D vision, normally we use the 2D laparoscopic camera. So 2D vision is problem is that you cannot make assessment of depth unless you are an expert. I think 2D is good enough. But for beginners, when you are using a 2D laparoscope, you may not be able to assess the depth. Okay, so you may have problems in dealing with difficult cases when you cannot assess the depth. Especially in endometriosis, is very, very important to assess the depth to avoid injuries to ureter, rectum, etc. And suturing is a bit difficult part. It takes a long time. Unless you keep practicing, suturing becomes difficult. And many times you have to use both vaginal and abdominal approach in laparoscopy, unlike in open surgery. Advantages are many. It is like the name suggests, it is minimally invasive. Patient recovers very fast. And biggest advantage is that you have a very high definition vision nowadays, making surgery very precise. And most important thing is that when you are doing a radical surgery, when you are doing a retroperitoneal surgery, you can visualize the pelvic nerves, the autonomic nerves, epigastric nerves, splanchnic nerves, which you'll never see in open surgery. So you can visualize them very nicely with laparoscope or with a robo. That is the biggest advantage of laparoscopy, visualization of the pelvic nerves. And nowadays, I think instead of doing a complete pelvic node dissection, many people are resorting to sentinel node biopsy, which is can be done by laparoscopy or robotic. Open also we can do it, but it's a bit difficult because we need a special camera for doing a sentinel node biopsy. I'll come back to it. Now, laparoscopy, definitely, if you are careful, you are enjoying your laparoscopic surgery, definitely bleeding is less. Skilled hands. But if you are not skilled, you will cause more bleeding and you will cause more problems. So patient recovers very fast. Even after major surgery, patient can be discharged home in 2 days or 3 days. And the additions are less compared to open surgery because you have a small incision. Now, laparoscopic surgery, completely adhesions cannot be avoided, especially in oncological surgery, because we are using dry carbon dioxide gas. We are using a dry gas, and gas, the pressure is under pressure, around 15 millimeter of mercury pressure. And the surgeries are prolonged. In cancer, surgeries are prolonged for 3 hours, 4 hours. So whenever the peritoneal cavity is exposed to dry carbon dioxide under pressure for more than 2 to 3 hours, then it will damage the peritoneum. It will damage the normal peritoneum and it may induce adhesions. So prolonged surgery can always injure the peritoneum, resulting in adhesions. So better to use humidified and oxygenated carbon dioxide to prevent adhesions if you are going to do for long surgeries. But I don't think anybody is doing it in practice. Now, most important thing while doing surgery in the pelvis is that patient requires deep tunneling birth position, especially if patient is obese. Obese patient, laparoscopy has got advantage. Also, it has got a drawback. Drawback is that the intestines keep coming in the way. They keep popping up into the pelvic cavity. So you require a deep tunneling birth position, especially in patients who are obese and elderly patients. And those patients with COPD or obese, giving a steep tunneling position becomes very difficult for the anesthetist. Anesthetist will straight away refuse to give anesthesia unless you have a good anesthetist. So it's very, very important to have a good anesthetist, especially if you want to operate on obese patients. Especially if you want to operate on patients with COPD. Ordinary anesthetist will refuse laparoscopic surgery. They will ask you to do open surgery, which is also very difficult. Obese patient, whether you do laparoscopy or open, both are difficult. But I think laparoscopy has got advantage if you have a good anesthetist. Now coming to port placement. Port placement in oncology is same, just like general gynecology. You have a main 10 mm port, which can be in the modified Palmar point. That is above umbilicus and just lateral to the umbilicus. Or you can just put it above the umbilicus, where you have 2-layered rectus sheath. So chances of getting hernia is less if you put a supraumbilical port because you have double-layered rectus sheath. Okay, then you can put 5 mm port, 2 on the left side, 2 on the right side. So you can put four 5.5 mm ports. Sometimes you are expert, you can manage with 3 also. But don't hesitate in putting more ports. It will make your life much more comfortable. So better to have 3 to 4 5.5 mm ports. Now technique of primary 10 mm port entry. Now I normally directly insert the 10 mm port. I don't use Veris needle. I never used Veris needle. Sometimes when patient has got a previous history of multiple surgeries, then I do open placement of 10 mm port. Primary port is the most important port. I think that is the most difficult part of surgery. If you are able to put the primary port, then half of your job is over. Then be familiar with multiple energy sources and you have to get used to particular energy source. You can use the monopolar cautery, which is faster and easier, but dangerous also. Okay, especially for doing a calpotomy, monopolar cautery is very good, but you have to have a control over the cautery. Otherwise, you may injure the surrounding structures. Bipolar cautery is very important. Even though you have harmonic, bipolar cautery is always required, I feel. Only problem is that it has got a lateral spread, 7 to 10 mm lateral spread. And this can be taken as an advantage. This is not a drawback. Lateral spread of bipolar energy is not a drawback because it will cauterize the surrounding vessels. So the bleeding is going to become less with bipolar. Then nowadays you have many other energy sources, NCL, ligashore, harmonic. where the lateral spread is much less, 1 millimeter to 3 millimeter. This is an advantage as well as a drawback. Advantage is that you can use it very close to the ureter, you can use it very close to the intestines. Drawback is that because you do not have lateral spread, the surrounding small vessels will start bleeding. So that is the drawback of NCL, ligashore and harmonic. So you have to have both bipolar and you have to have harmonic also. Both are important. Nowadays in India, especially, many people have switched over to endoscopic shearer, where you use very high voltage current up to 200 volts, and it does coagulation, bipolar coagulation as well as cutting. Locally made, much cheaper compared to harmonics. It's good for dissection also because the blades are sleek and curved. You can see the picture here. The blades are sleek and blades are sleek and they are curved. So it is bipolar dissector. This is the bipolar dissector. High energy voltage current is used. So instead of harmonic, many people have switched over to shearer, what is called as bipolar shearer. You don't have to use expensive hormone. Personally, I am using harmonic. I'm used to harmonic and I don't want to change right now. I'm comfortable, a bit slow. Harmonic is a bit slow compared to shearer, but much safer, I feel. Then specimen retrieval is very, very important in oncology because you cannot cause the spread of cancerous cells. So initially, I used to remove the lymph nodes through 10 mm ports initially. Okay, I used to put one more, I used to remove the 5 mm lateral port and put 10 mm port laterally. I used to remove the lymph nodes through 10 mm port. But what happens is that if you have a node which is bigger in size, it gets crushed. The node gets crushed. So you can cause spillage of cancer cells. So nowadays I've stopped using port, 10 mm port for removing the lymph nodes. Whether small or big, I don't use port. I prefer to remove the lymph nodes vaginally after hysterectomy. Much more easier, much more simpler to remove the lymph nodes vaginally after hysterectomy. Sometimes when you have to do a conservative surgery, then you can do a posterior colpotomy with intact uterus and remove the specimen in endobag. Or sometimes you not familiar with posterior colpotomy, then you can remove the specimen abdominally through a small incision. Most important thing here is that you have to use endobag if suspecting malignancy, or even for dermoid cyst also better to use an endobag to prevent spillage of sebaceous material into the peritoneal cavity. So here, this is the posterior colpotomy picture here. Endobag is being put here. This is the posterior colpotomy picture. This is the uterosacral ligament here. Incision is made in the posterior fornix, which has been bulged by putting a pressure from vagina. And this is the endobag which has been put, and all the specimens are put into the endobag and removed. Now, precautions, movements of the instruments need to be precise and gentle and fine to avoid capillary oozing. And most important thing is that if you're switching from open surgery to laparoscopic surgery, slow down, don't hurry up, don't compare open surgery with laparoscopic surgery. Slow down, enjoy your work. If you enjoy your work, you'll save time. So this is the, I told you, standard port placements in oncology. It is enough for almost all the oncological surgeries. This is the 10 mm port, supraumbilical, 2 ports on the left side, 2 ports on the right side, 5.5 mm. Better to use 5.5 mm ports, not 5 mm ports, because the harmonic instruments move easily in and out through 5.5 or 6 mm ports.
Hello? Barre.
Now, port placements need to be flexible. There is no hard and fast rule. You can also have, instead of 4 lateral ports, 2 on the left side, 2 on the right side, you can also have a suprapubic port in between the umbilicus and symphysis pubis. So you can be flexible depending on your ergonomics, depending on your habits, depending on whether you are standing on the left side of the patient or right side of the patient. Port placement need not be fixed. You change according to your needs. So instead of 3 assistant ports, you can have 4 or even 5 assistant ports. It should be 6 mm, not 5 mm. 5.5 or 6 mm. Now, when the patient is obese, what happens is that sometimes the intestines will keep coming in the way. So here I have shown that this is the sigmoid colon epiploicae. Epiploicae, you can be pierced by a T lift, what is called as T lift here. T-shaped tube which has been pierced through the epiploicae of the sigmoid colon, and this can be used to pull the sigmoid colon up out of the pelvis. And 30-degree camera is better than 0-degree camera for complex oncological procedures. I don't use 0-degree camera. I always use 30-degree camera. It gives you very good lateral vision. So always in oncology, use 30-degree camera. And most important thing, if you are learning laparoscopy, is that you have to develop a team. You cannot do it alone. You have to develop a team with a dedicated camera assistant. You have to have a good camera assistant. Otherwise, you will get frustrated. You have to have a dedicated second assistant, dedicated vaginal assistant for uterine manipulation if you are doing uterine manipulation, dedicated scrub nurse, dedicated flow nurse. If you have a dedicated team, you will save a lot of time. 2-hour surgery will become 1-hour surgery. If you are going to a new place and operating, it will be a hell. So better to have a own team, good team. Now with dedicated, if you have a good team, surgery becomes enjoyable. Start enjoying laparoscopy. Unlike not like doing open surgery, you start enjoying laparoscopic surgery. It becomes a fulfilling experience. It becomes an art if you have a good team. Otherwise, without a good team, without a proper functional instruments, it becomes very dangerous. You get frustrated, you will cause more problem. So always do slowly, have a good team. Take your own time. Then now coming to the, I think when you are doing a pelvic surgery, sometimes you need a steep position. Here you can see the picture, you can see steep position. And whenever you are giving a steep position for a prolonged time, better to have good stirrups. Especially in obese patients, it's very, very important to have good stirrups. Because if you don't have good stirrups, a patient will develop joint pain, back pain, and the nerves will get compressed. So better to invest in these kind of good stirrups. Don't do laparoscopic surgery with ordinary stirrups. Especially in obese patients, elderly patients, you'll injure the pelvic nerves. You will injure the hip joint. And whenever you are giving a position like this, especially in obese patients who have COPD, you have to give a positive pressure ventilation. You have to give a positive pressure and ventilation. So the anesthetist has to be trained. Anesthesia is very, very important. Without positive pressure ventilation, patients' abdomen will be moving, intestines will be moving up and down. So you have to have a good positive pressure ventilation, especially for obese patients, especially for patients with COPD. Laparoscopic surgery needs tremendous amount of patience, especially if you don't have a trained team. Switching from open surgery to minimal invasive surgery is an art. Requires change in attitude. Don't try to be fast. Do it slowly. Don't compare with open surgery. Then learning has become very easy nowadays. Easy and fast. If you are young, 30, 35 years old, 40 years old, you can learn laparoscopy very, very easily than if you are a 60 years old man or a woman. So surgery is very easy these days because you have so many seminars, so many you can watch surgery on YouTube. Make it a habit to watch a surgery every day on YouTube, and you learn surgery very fast. You watch different surgeons doing surgery, and you have beautiful surgeons in India nowadays. Very great surgeons you have in India doing excellent job. You'll enjoy watching the videos on YouTube. Then very important thing, apart from doing a steep tunneling position, I think better to put a sandbag, especially in obese patients. Sandbag behind the pelvis. It will help the intestines to fall back into the abdomen. So I always use the sandbag behind the pelvis, and I find that the intestines don't come in the pelvis. So surgery becomes much more easier. Obesity makes surgery much more challenging because of bulky bowel loops, bulky omentum, thick abdominal wall, inability to tolerate steep tunneling position. Obesity is a problem also, but at the same time, it is an advantage for laparoscopic surgery. Recovery is very fast, but you have to have a good anesthetist. Now coming to laparoscopic surgery indications in oncology, most important thing is that whenever you have an adnexal mass, you don't know whether it's benign or malignant. Instead of doing a laparotomy straight away, you can always do a diagnostic laparoscopy. If the investigations like MRI scan is not conclusive, you can go for diagnostic laparoscopy. So very easy. As soon as I put laparoscope, you will make diagnosis. Here you can see imaging was not conclusive on ultrasonography scan. As soon as I put scope, you will find that there is a fungating growth on the ovary. So diagnosis of malignancy becomes very, very easy as soon as they put. And these small tumors, you can manage the entire procedure: hysterectomy, bilateral salpingo-oophorectomy, pelvic lymph node dissection, omentectomy. Everything can be done by laparoscopy. If you have a small malignant tumor, these tumors can be removed intact after hysterectomy by vaginal route. This is again diagnostic laparoscopy. Then now coming to CA ovary. CA ovary normally is managed by laparotomy. But as I mentioned to you, it is possible to do laparoscopy for CA ovary also, provided you are removing the tumor intact. Provided you are removing the tumor intact vaginally, or you are removing the tumor in the endobag without causing spillage. So this is a small tumor here with ascites here. Easily you can do laparoscopy. Complete surgery can be done laparoscopically. There are no abdominal metastasis. Tumor is confined to the ovary. So definitely you can do surgery laparoscopically. So CA ovary laparoscopy is not contraindicated. Now omentectomy becomes very easy laparoscopically. This small video clip, that is what you're seeing is stomach here. And always you have a vessel over the lesser sac. This is a constant vein covering the lesser sac. Once you coagulate this vein, you will directly enter into the lesser sac. So this is the lesser sac here, opening here. I don't know whether you can understand this. So we have to do a total omentectomy. That means removing the omentum from the stomach. This is a lesser sac which has been opened. Stomach is here, transverse colon is here. This is the lesser sac. Transverse colon, stomach. This is the lesser sac which is open. So omentectomy can be done quite easily by doing laparoscopy. Not difficult, provided omentum is not having much of metastatic deposits. This is an old video. I think I've done it nearly 5 years back, 6 years back. So it requires a bit of orientation initially. And this omentum can be easily removed by vaginal route. After omentectomy is over, you can remove the omentum vaginally. Not difficult. Okay. Now coming to aortic node dissection also. Same ports, I am doing aortic node dissection, and ovary you don't have to remove all the lymph nodes. Dictum is that you have to remove only the bulky lymph nodes. So I made an incision over the midline, the retroperitoneal area. You can see vena cava here, and a small bulky node is there which is being removed by laparoscopy. You don't have to remove all the nodes. Only bulky nodes have to be removed. What you're seeing is the vena cava there. You can see a small node, bulky node, which is being removed. No need to remove all the node. No need to do a thorough lymph node dissection. Lymphadenectomy is not therapeutic. Lymphadenectomy in cancer is not therapeutic. It is only diagnostic. Any solid cancer, lymphadenectomy is only diagnostic. You can see vena cava very clearly. Made a small incision. Very small incision, and you can remove only the enlarged nodes. No need to remove small nodes. Slowly go up, and we will see the aorta also. Slowly you can extend the incision as and when required. Don't make a big incision in the beginning itself. Slowly go up, and you will see the aorta, and that is the duodenum. Here, this part will be the duodenum here. on top. This is the common iliac arteries. These are the common iliac arteries. Slowly go up. I think because of lack of time, I will proceed to the next. Slowly you can do. Now pelvic node dissection also very easy. Now you can see here pelvic node dissection is very good. You can do it very nicely. You can do it. This is the external iliac artery you are seeing here. And again in CORE you have to remove all the bulky nodes. In CA cervix and CA endometrium, better to remove, especially in CA cervix, better to remove all the lymph nodes. In CORE, you have to remove only the bulky nodes. So surgery, see, almost it becomes bloodless, simple surgery, provided you have a good team, you have good equipment. Such a nice instrument, this one, NCL. Almost no bleeding at all, absolutely. No bleeding, no lateral spread. Surgery is very safe, bit slow compared to shearer. But no lateral spread, very easy to do it. You start enjoying it. Yeah. Now, when you are doing surgery, don't rupture. Whenever you are doing surgery for ovarian tumor, I've seen many gynecologists venturing into gynec oncology, but they rupture the tumor. Should not rupture it. Scanning is showing a tumor, cystic tumor with solid area. We know it is malignant. Still, I see many gynecologists, they are good surgeons, famous surgeons, but they want to do surgery. Somehow they want to do surgery for even oncology cases. They rupture the tumor and cause the unnecessary spread. Just because you are a good surgeon, just because you are famous, you cannot do all this. Let me noted. You cannot do somebody's life. You cannot play with somebody's life. Accidental rupture is okay. Accidental rupture of cystic masses occurs approximately 10% of laparotomies, as compared to 70% in minimal invasive surgery. Rupture during laparoscopy is more dangerous than rupture occurring in open surgery. Open surgery, the rupture is not under pressure, and immediately you are sucking out all the fluid. In laparoscopic surgery, whenever the tumor ruptures into the abdominal cavity, the abdomen is under pressure. So the cells will get implanted into any raw area. So laparoscopic rupture is more dangerous than rupture occurring during open surgery. So avoid rupturing the tumor. Now, many times female women comes with ascites, don't know what is the cause. Laparoscopy is a very good tool. Any ascites, there are three causes. In adult women, there are only main three causes: tuberculosis, malignancy, and cirrhosis. These are the three causes of ascites, which sometimes are difficult to diagnose by imaging. So laparoscopy, immediately you can diagnose cirrhotic liver, whether it is GI cancer, whether it is ovarian cancer, whether it is a primary peritoneal cancer. Diagnosis becomes instantaneous with laparoscopy. So a very, very good tool to differentiate a benign tumor from malignant tumor. Very good tool to diagnose cirrhotic liver. Very simple and easy tool. Now coming to, after ovary, coming to role of surgery in endometrium. Nowadays, I think 90% of all the surgeries are being done by laparoscopy. See endometrium, 90% of surgeries are done by laparoscopic surgery. There are a few exceptions where minimal invasive surgery is not preferred. So don't do it for all the cases. Okay. So if you have a 10 weeks uterus or 12 weeks uterus, vagina is lax, you can remove even 10 weeks uterus, or you can remove even 12 weeks uterus. Multiparous women with lax vagina, with cystocele, rectocele, uterus is big, you can remove it. But sometimes in an old woman, you have a uterus which is just 6 to 8 weeks, but the vagina is stenosed, atropic vagina. You cannot remove even a 6 to 8 week uterus when vagina is stenosed. So avoid doing surgery if you are not going to remove the uterus intact. Don't morcellate the uterus. You can use uterine manipulator. Uterine manipulation will not cause any harm. But don't use myoma screw. Don't use myoma screw because you are going through and through the uterus and may enter the endometrial cavity, and the cancer cells may spill into the abdominal cavity, which is under pressure. Uterus should be, again, I'm telling you, uterus should be removed intact. I've seen again, many people are doing surgery for C endometrium for 10 weeks uterus, 12 weeks uterus. morcellating it partially and removing it vaginally. Just because you're an expert surgeon, you cannot do it. Obese patients, as I mentioned to you, benefit from laparoscopy, even though anesthesia with steep tunneling birth position is difficult. You require high pressure ventilation, and you have to require a good anesthetist to do laparoscopy on obese patients. Again, port placement, coming back to same thing. Nowadays, I use 3D laparoscope, 3D high definition laparoscope, or I also have a 4K instrument with which I can do a sentinel node biopsy. I can do a sentinel node biopsy with 4K Karl Storz laparoscope. So these are the port placements for C endometrium. The entire procedure, TLH, BSO, pelvic node dissection, aortic node dissection, omentectomy can be done without changing camera, without changing the camera or any other instrument. You can do everything without changing the camera. Now coming to CS cervix. CS cervix, we can do laparoscopy for stage 1A, that is microinvasive cervical cancer. 1B1 type 3 radical hysterectomy was being done for a long time. Okay. Nowadays, we don't advise laparoscopy for CS cervix. This is the video of steps of this thing. And why you should not do laparoscopy for CS cervix? These are all excellent steps. Whether you do laparoscopy or open, these steps are not going to cause increase in the morbidity. Then why laparoscopy is not being advised for CS cervix? See, this is ureteric dissection, that is the uterine artery. Ureter deroofing has been done, very short clip. Opening the pouch of Douglas. Pouch of Douglas is being opened. Okay. Now, the uterosacral ligament is being cut. The problem here is that if you are inexperienced, you may remove less of uterosacral ligament. Here you see we are removing little less of uterosacral ligament. This is the parametrium, that is cardinal ligament. This is the ureter. This is the ureter. This is the cardinal ligament. This is what is called as Ebuki space. Ebuki space. Under this space, you will have the nerves here. If you go a little deeper, you injure the nerves. So the parametrium has been cut. And final step is the most important step, which is going to cause problem. That is colpotomy is the most important. This is the Ebuki space. Here you have nerves. Now this is the most important step. Watch these two videos. This is a good way of doing colpotomy without causing spillage of tumor. You can see the ureter here, umbilical artery. This is the vagina. This is the bladder. And you are doing a colpotomy here with good margins without causing spillage. But sometimes spillage is not in your hands. Depends on how tired you are, how good is the assistant, how big is the tumor. Spillage can happen without your knowledge sometimes. That's why for CS cervix, laparoscopy is not being advocated nowadays, unless you take precautions to avoid spillage. So here you can see there's no spillage here, but just look at this video now. This is robotic. See, look at all the instruments are completely, the tumor is completely adherent to the instruments. You can see that the tumor has broken through here. So definitely on the right side video was bad video, where the tumor spillage is occurred. Here there's no spillage here. Tumor is very small. So should not do laparoscopy for very large CS cervix, 1B2. Maybe for 1B1 you can do it. 1B2 should not do it, because you will spill the cervical tumor. into the abdominal cavity. Unlike C endometrium. C endometrium tumor is confined to the endometrial cavity. You don't spill the tumor. Unlike C cervix. C cervix, you can spill the tumor into the abdominal cavity, which is under pressure. So this is the trial, after which the whole scenario changed. This trial was published way back in 2018. It's called as LAC trial, locally laparoscopic surgery for cervical cancer. LAC, LAC trial showed increase in risk of recurrence for laparoscopic surgery. Also, the American data, it's called as SEER data, showed that laparoscopic surgery increased the mortality due to disease recurrence. If you do CA cervix by laparoscopy, the mortality rates are increased. Conclusion, laparoscopic surgery in gynec malignancy is increasing, especially useful in GI endometrium, and also useful for staging ovarian cancer. Very good for endometrial cancer. Thank you so much. I'll hand over the mic to chairman.
Excellent talk,
Thank you,
sir.
sir.
Very excellent talk.
Thank you so much, sir, for the brilliant presentation on malignancy and minimally invasive surgery, and also enlightening us on when to do what, and how much do you agree for CA endometrium, sir? Till what, and who can do? Even a general gynecologist. As general gynecologists, we may encounter it on our practice, even on table sometimes. So what do you suggest, or what is your take-home message for people who encounter or get a case of CA endometrium and they are at tier 2 and tier 3 cities, they can't approach you. So what do you advise them?
Oh, CA endometrium comparatively is a good malignancy. Okay, the 5-year survival rate is 90%. Very good malignancy. Except if you are thinking of high-risk endometrial cancer. So whenever you are doing a surgery, right? Okay, if you have done a surgery for endometrium, because most of them belong to a low-risk category, they will do very well. Only thing is that when you have a grade 3 tumor, when you are doing a biopsy, endometrial biopsy, you have a grade 3 tumor, or you have a very big uterus which cannot be removed intact. Those cases, I think, should be avoided. You should not do laparoscopy. Okay. Otherwise, suppose many times what happens is that you preoperatively you have a report of complex hyperplasia with atypia, and finally it turns out to be endometrial cancer. This is a very common scene. You have done a biopsy showing endometrial hyperplasia or endometrial hyperplasia with atypia, but postoperatively it turns out to be carcinoma endometrium. So nothing to worry, as long as the endometrial cancer is confined to the endometrium and invasion into myometrium is minimum, I think nothing more is required. A simple hysterectomy with bilateral salping oophorectomy is good enough. There's no need to remove the lymph nodes at all. So I think small tumors confined to the endometrium with minimal invasion of myometrium, I think you can straight away go for TAs and BSO. No need for lymphadenectomy.
The role of ICG, sir, do you advise that every case we should inject ICG and look for the
yeah, ICG is a new field. If you are believing in a sentinel node biopsy, I had a video. In fact, if you want, I can show it to you. You want a video? I can, if you have time, I can show you. Otherwise, it's okay. No, I can't hear you.
Sir. Please show us, sir. We would like to see that.
One second, just give me a second.
Arun?
Just give me a second, please.
Okay, no problem.
I have to look for. Are you able to see it now? No.
No, sir.
I think I have to share my slides. One second. Let me share my slides. longer time. Once again, I think I'm not able to share the slides. Okay. Okay, this is a video of laparoscopic sentinel node biopsy. Initial picture is blurred, but afterwards it becomes clear. This is done by a simple laparoscope using a near infrared camera. You can see the green dye just come to the lymph node.
It's
The
not-
principle
Sir,
is
we
that-
can't see the video.
No, video is not. No, you can't see.
No, sir.
No, sir, we can't see the video.
One second. I'm sharing the slides. How come it's not seeing?
That video got selected, but it's not playing.
I think
it's not
the previous thing is coming. I think.
ಸರ್ ಅದು ಹಂಗೆ ಇದು ಕಂಪ್ಯೂಟರ್ ಇದಷ್ಟೇ ತೋರಿಸ್ತಾ ಇದೆ ಎಲ್ಲ ಇದ್ರು.
Showing your desktop, sir, but it is not showing the
Yeah, I'll show you. No, because the previous slides were, I think, being shown. Are you seeing now? No.
No, sir, it's not
No, sir.
downloading.
It's not
No.
downloaded.
Oh my God.
Sir, do you advise a routine sampling of lymph nodes? Suppose the patient, there is a suspicion. We don't have a proper report, but do you advise a routine sampling of lymph nodes, sir?
Whenever the lymph nodes are big, more than 1 centimeter, then better to sample them always.
What is the role of MRI, sir? Suppose
No,
in a
I think
field of
if you don't want to land up in problem, for CA endometrium cases, all cases should have MRI scan done. All cases.
okay, sir.
So that it
That's-
will
that's a
large
very,
lymph nodes.
very important take-home message, because we often forget to understand the role of MRI in gynae practice. So I think that's a very important take-home message for us, sir, and also the sampling.
Yes. Once again, let me share again. Are you seeing the video now?
No, sir, it's the same.
No, sir, it's the same.
How come it's not showing? Stop sharing. Let me try last time now.
Sir, can you copy that video to the desktop and share it, sir?
This is on the desktop only.
No, sir, it is in a folder itself.
Okay. Let me copy it. Okay.
Copy it to the desktop and play it, sir.
How's it now?
No, it's the same.
No, sir.
How come I copied on the desktop now?
Sir, close this folder, sir, first. Minimize or close it, sir.
Okay. I don't know.
Sir, regarding the para-aortic sampling, do we have to check with ICG dye and then send a frozen section and then do a para-aortic sampling?
No, frozen section is not reliable for sentinel node biopsy. When you injected ICG dye, And the dye usually goes to pelvic lymph nodes only. It doesn't go to aortic nodes. So sentinel node biopsy is not very good to pick up aortic lymph nodes. Okay, at the most it will go to the lower aortic lymph nodes because the dye is injected into the cervix and it will only cover the pelvic lymph nodes. And at the most it will cover the lower aortic nodes. But in say endometrium, usually the upper aortic nodes are involved. Okay, the aortic nodes are not picked up by sentinel node biopsy. So ICG sentinel node biopsy is not good to pick up aortic lymph nodes. But the most important thing is that in CA endometrium, almost always the pelvic lymph nodes are involved. And without involvement of pelvic lymph nodes, aortic nodes are not involved. Okay, that is the rule. As a rule, pelvic lymph nodes are involved first. Only after the pelvic nodes are involved, they go to aortic lymph nodes. That is the rule. So if you have a pelvic sentinel node biopsy, that is enough. You have to remove only the sentinel node. And you don't have to do frozen section. The sentinel node is removed and sent to laboratory. And the lab pathologist has to do what is called as ultra staging. Because you are removing only 1 or 2 nodes. So pathologist has to be extra careful. They cannot do a simple H&E staining. They have to do what is called as ultra staging. They have to take sections at 50 to 100 microns. And they have to use immunohistochemistry with cytokeratin stain. Only then the sentinel node biopsy is complete. Okay. And
we have to ask for it. Suppose we do, we have to ask for all these things.
You have to ask for it. Otherwise, no point in doing sentinel node biopsy.
Sentinel node. Okay, sir. Yeah.
And there's no need to remove all the other nodes because lymphadenectomy is not therapeutic.
Yeah, correct.
Lymphadenectomy is only diagnostic.
Yeah.
So whether you remove 1 lymph node which is positive or 10 lymph nodes which are positive doesn't matter as long as the lymph nodes are macroscopic, small lymph nodes. So the rule is that you remove the sentinel lymph node and you have to remove all other bulky nodes, whether they are positive or negative.
Sir, we subject them for brachytherapy?
No, brachytherapy is not required for all cases.
Okay.
There are different indication guidelines are there. Only then you have to do by brachytherapy.
Okay.
That is a big chapter by itself.
Okay.
Okay. Nowadays you have what is called as molecular pathology. So simple pathological examination is not enough, especially for CA endometrium. We have 4 different categories of molecular classification for CA endometrium. So all the cases should have molecular immunohistochemistry, wherein you can group CA endometrium into 4 categories. The 4 categories are: 1 is pole mutation, 2nd is MMR, mismatch repair gene mutation, 3rd one is P53 mutation, and 4th one is non-specific molecular profile. So these are the 4 molecular signatures of CA endometrium. Based on this, you can decide when to give chemotherapy, when to give radiotherapy, and when to give brachytherapy.
Thank you so much, sir. Thanks for the information. Any other questions from the audience? Anybody else who wants to ask questions? Because most of the time, sir, we land up with CA endometrium. When it is CA cervix, we know it is Bafna, sir. But on table, we land up with this. And sometimes even the diagnosis is not there with us. So that time, for us to be...
I think that is okay. I think only thing is the only issue is that you should not morcellate the uterus. Because once you morcellate the uterus, suppose uterus was very big and you morcellate it, then spillage is occurred. Once spillage occur, where the cells are spilled, we don't know. Yes. It can go anywhere into the abdominal cavity. So repeat surgery will not help. Chemotherapy also will not help. Radiotherapy also will not help. So morcellation should be avoided.
Thank you, sir.